I would like to thank Sages for inviting us to present our data. I have nothing to disclose. How do I move forward? This one? Oh, this one, okay. So ventral hernia is a conventional surgical problem. About 350,000 ventral hernia repairs are performed in the US each year. 200,000 of those are incisional ventral hernia repairs. They create an estimated direct cost of $3.4 billion per year. Recurrence rate remains high even nowadays despite the wide use of mesh. And complications can be as devastating as mesh infections and endocotaneous fistulas. They present, like my previous speaker said, in emergent and elective settings. We're always faced with the decision, should we operate or not operate? There are objective and subjective factors that play into that decision. And the challenge is often in patients with significant comorbidities to weigh the possible benefits of a ventral hernia repair against increased risk of morbidity and mortality in those specific patients. So our study objective was to evaluate the national series of open laparoscopic ventral hernia repair to assess for factors associated with mortality after elective ventral hernia repair. The study may provide some guidance in the decision-making process and patient counseling. This is a retrospective analysis of 2008 to 2014 healthcare cost and utilization project nationwide inpatient sample. NIS contains about data of 7 million yearly hospital admissions. It's a 20% stratified sample of all discharges from US community hospitals. It contains data of all the different patients regardless of payer, and it's sampled from the state inpatient database. It covers about 97% of the US population, so it's a strong database from that perspective. Inclusion criteria were a main diagnosis of abdominal cavity hernia. We excluded inguinal, femoral, and diaphragmatic hernias, and the DRG code related to hernia procedures, again, excluding inguinal, femoral, and diaphragmatic. We then stratified our data by elective versus emergent and laparoscopic versus open. We looked for factors associated with same hospitalization mortality, and all factors that on univariate analysis showed a value of less than 0.1 were included in a multivariate analysis, and the endpoint was mortality in the same hospital admission. We identified 103,635 patients. Mean age was 57 years, 61.4% were females. The majority, with 61.5%, were incisional hernias, followed by other hernias and umbilical hernias in 14.3%. 215 patients presented with gangrenous contents of their hernia sac. There were 57.9% elective cases. Laparoscopy was used in 21.3% of elective cases and 13% of emergent cases. Again, usage of laparoscopy is still low, like my previous speaker said. Mesh use is high, 87.7% for elective cases and 65.3% for emergent cases. Mortality is relatively low, with 0.2% in elective cases and 0.6% for emergent cases. Mortality in the elective group was similar for the laparoscopic and open group with 0.2%, while in the emergent group, laparoscopic ventral hernia repair had a lower mortality with 0.4% compared to 0.6%. Median length of stay was a little bit shorter for the laparoscopic group with 2 days versus 3 days. We then run the multivariate analysis looking at mortality during hospitalization. And for elective ventral hernia repair, it identified the following factors as being significant: age greater than 50, male gender, CHF, pulmonary circulation disorder, coagulopathy, chronic liver disease, fluid and electrolyte disorders, metastatic cancer, neurologic disorders, and paralysis. Therefore, we conclude ventral hernia repair has a low mortality, especially when performed laparoscopically. However, in elective ventral hernia repair, higher mortality was observed in older patients with comorbidities, as previously mentioned. And therefore, I think we should consider conservative management for patients that have these high-risk factors in context with the overall clinical presentation. Thank you.